This module will cover acute kidney injury and chronic kidney disease. So the words kidney failure and renal failure can kind of be used interchangeably in medical terms. These can usually occur in only two types: acute kidney injury and chronic kidney disease. We'll go more into depth with each of those. So this is a comparison of acute kidney injury versus chronic kidney disease. Acute kidney injury, sudden, acute tubular necrosis is the most common cause. You have acute reduction in urine output and or an increase in serum creatinine, potentially reversible. Main cause of death is usually infection. The other thing to know about acute kidney injury is, although you would think acute being short term, it can take 10 to 12 months to recover from acute kidney injury. Chronic kidney disease, gradual, often over many years. Most common cause, diabetic neuropathy. Diagnosis criteria, it's all about the GFR, which we'll go more into, and or kidney damage longer than 3 months. It is progressive and irreversible, and the most common cause of death is cardiovascular disease. So important thing to know and to focus on is the categories and etiologies of acute kidney injury. There are three kinds: the pre-renal, intrarenal, and post-renal. You'll be able to know, or you should be able to identify which broad category which goes with each kind of acute kidney injury. An example, damage to the kidneys due to a nephrotic drug, such as furosemide or Lasix. This would be intrarenal because it is in the kidneys within themselves. Really, other ones like pre-renal are related to blood not being able to reach the kidneys. And post-renal is something is blocking from the kidneys down lower. So these are important when you're looking and going through your notes. This is an important thing to study. So acute kidney injury clinical manifestations is really the rifle classification. This is risk, injury, failure, loss, end-stage renal disease. This classification is important, so really look at those, especially when it comes to the end-stage renal disease going into chronic kidney disease. So there are three main phases of acute kidney injury. The first one being the oliguria, which is a reduction of urine output to less than 400 mils per day. Usually occurs of 1 to 7 days of the injury to the kidneys. If the cause is ischemia, oliguria will often occur faster, usually within 24 hours. Duration of the oliguria phase lasts on average from about 10 to 14 days, but can last sometimes months. The longer the oliguria phase lasts, the poorer the prognosis. So really you want a faster recovery. UA may show cast, RBCs, and white blood cell count. Casts are formed from mucoprotein impressions of the necrotic renal tubular epithelial cells, which detach or slough off into the tubules. Fluid volume, with a decrease in urine output, there's usually an increase in fluid retention. So you're going to see things like neck vein distension or JVD, bounding pulses, edema, hypertension. Fluid overload can lead to heart failure, sometimes irreversible heart failure, pulmonary edema or backup of fluid into the lungs, and pericardial and pleural effusions. Usually the severity of the symptoms really depend on the extent of the fluid overload. Metabolic acidosis. In kidney failures, the kidneys cannot synthesize ammonia or excrete acid products of metabolism. So usually the bicarb levels decrease because bicarbonate is depleted in buffering hydrogen ions. So also defective reabsorption and regeneration of bicarb occurs. With development of severe acidosis, the patient may develop what's called Kussmaul's respirations, which is the rapid deep respirations in an effort to try to compensate by increasing the exhalation of the CO2. Sodium balance also occurs. Damaged tubules cannot conserve sodium, so the urinary excretion of sodium may actually increase. So you're actually going to be seeing some hyponatremia or normal to below levels of serum sodium. This can lead to cerebral edema, which can be fatal as well. Potassium excess. Anytime you think potassium, think EKG, think one of the most deadly electrolytes. So kidneys normally excrete 80 to 90% of the body's potassium. So in acute kidney injury, the serum potassium increases because the kidney can't excrete the potassium as well. Patients with hyperkalemia may have no symptoms. That's what makes it most deadly. And then all of a sudden, acute and or rapid development of hyperkalemia may result in the clinical signs in an EKG. These changes include peaked T waves, widening of the QRS, and ST segment depressions. This is a good picture of hyperkalemia, what it can look like on an EKG. As you can see, especially in like view 2, that very extensive peaked T wave. That is a very big indication of hyperkalemia. The QRS will then begin to widen as the potassium gets worse, and then this can lead to fatal cardiac issues. Then it moves into the diuretic phase. The increased urine volume is caused by osmotic diuresis from the high urea concentration in the glomerular filtrate and the inability of the tubules to really conserve that urine. So the kidneys have recovered their ability to excrete waste, but not to concentrate urine. So it almost goes from one end to the extreme other end. Because of the large losses of fluid and electrolytes, we really are looking for hyponatremia, hypokalemia, and dehydration. The diuretic phase really can last 1 to 3 weeks. Near the end of the phase, the patient's acid-base electrolytes and waste production, like the BUN creatinine values, will begin to normalize. Then you move into the recovery phase. This begins when the GFR starts to increase, allowing the BUN and the serum creatinine levels to plateau and then decrease. Although the major improvements occur in the first 1 to 2 weeks of this phase, this can take up to 12 months to stabilize at this point. The outcome of a patient's AKI is influenced by the patient's overall health, the severity of kidney failure, and the number and types of complications. Diagnostic studies, you really want to do a thorough history, dehydration, septic shock, blood loss, or severe heart disease. Then really you're going to look at increased serum creatinine greater than 1.3, may not be evident until there is loss of greater than 50% of the kidney function. That's a huge amount of the kidney function before you see the serum creatinine change. So that's going to be a later finding. Urinalysis is probably one of the most important diagnostic tests. Urine osmolality, sodium content, and specific gravity are also measured, including urine, sediment, hematuria, pyuria, and crystals that may be seen. Kidney ultrasound, usually one of the first ones that's done, It really provides imaging without exposure to potentially nephrotic contrast agents. That's huge with the kidneys, is anytime you see, oh, they're going to go get any kind of scan, that contrast really is nephrotoxic. So we want to make sure their body can actually process that. That ultrasound will show kidney size and obstructions, etc. Renal scan may help assess for abnormalities in like kidney blood flow, tubular function, collecting systems. And then if you need to, you can move to a CT scan, which can identify lesions, masses, obstructions, and vascular abnormalities. Renal biopsy really is considered the best method for confirming intrarenal causes of AKI. Contraindicated diagnostic studies really don't need MRI because the dye is nephrotoxic, or an MRA because it also uses that kind of contrast media. Primary goals, since AKI is potentially reversible, we're going to eliminate the cause, manage the signs and symptoms, and prevent complications and let those kidneys recover. We don't want to do anything that's going to make the kidney function worse. Treatment of hyperkalemia, which is one of the most serious complications of AKI, which can cause those life-threatening cardiac dysrhythmias. There's various therapies that will treat that high potassium level. One that you'll see a lot is insulin and sodium bicarb. You'll see lots of test questions, lots of ideas of patients that are like, why am I getting insulin and I'm not diabetic? A lot of times it's because of this high potassium. So we'll give insulin and sodium bicarb, usually given over 5 minutes in the hospital setting. And that's trying to promote a shift of potassium into the cells, but the potassium will eventually be released. Usually with that, sometimes we'll give calcium gluconate. It's given IV in the hospital setting, which raises the threshold at which dysrhythmias will occur to temporarily stabilize that myocardium. One of the big meds that they also give is called K-Exlate. It's given PO. It can be given at home in dialysis centers. Actually removes potassium from the body. Never give this drug to a patient with paralytic ileus because bowel necrosis will occur. Reason being is K-exhalate means massive amounts of bowel movements to quickly remove the potassium from the body. This is explosive diarrhea to get the potassium out of their body. So if you think about it, if they have a paralytic ileus or their bowel is not moving, all of a sudden you give this med and it doesn't move through, it is going to kill that bowel. Nutritional therapy, you want to provide adequate calories to prevent different issues, but despite the restrictions, because you really are trying to balance electrolyte disorders, fluids disorders. But the primary goal is to maintain adequate calorie intake and prevent the further breakdown of body protein for energy purposes. Adequate energy should be mostly from carbohydrates and fat sources to prevent ketosis from indigenous fat breakdown and from muscle protein breakdown. Supplementation of essential amino acids can be given to kind of help out. Sodium is restricted as needed to prevent edema, hypertension, heart failure. Dietary fat intake is increased, so patient receives at least 30 to 40% of total calories from fat. You can actually give fat emulsion IV infusions as a supplement if people are not maintaining that. If a patient cannot maintain adequate oral fluid, internal nutrition is preferred route for nutritional support. It's better than nothing. When the GI system is not functional or the GI tract is not working as well, parenteral nutrition is necessary to provide adequate nutrition. Patients treated with parenteral nutrition, maybe daily like hemodialysis or CRRT to remove that excess fluid that we are giving them. In the hospital, there are factors that increase the risk for development of AKI, such as presence of pre-existing CKD, older age, massive trauma, major surgical procedure, extensive burns, cardiac failure, sepsis, and obstetric complications. Things that we're going to do: careful monitoring of eyes and nose and fluid balance. This is essential. So recording ins and outs, vomiting, diarrhea, hemorrhaging, increased insensible loss. All of those are important things to document. Prompt replacement of significant fluid loss will help prevent ischemic tubular damage associated with trauma, burns, extensive surgeries. So along with the eyes and nose, another big one is the daily weight, which will tell us the fluid volume status. Aggressive diuretic therapy for the patient with fluid overload can result from any cause, can lead to reduction in renal blood flow. We should use nephrotoxic drugs very sparingly in a patient at high risk. When these drugs must be used, they should be given in the smallest effective dose for the shortest amount of period possible. We'll go more into all the kinds of dialysis later, but the three kinds are peritoneal dialysis, intermittent hemodialysis, and CRRT, or continuous renal replacement therapy. Chronic kidney disease. The leading cause of chronic kidney disease is diabetes, about 50% of cases, and hypertension, about 25% of cases. A lot of those are reversible diseases, so catching those diseases earlier and helping patients manage those diseases are going to help us prevent chronic kidney disease. This is a big thing. Up to 80% of GFR may be lost before notable changes in body function occurs. So the kidneys can be actively dying, but there are no symptoms that the body is showing. Remaining nephrons hypertrophy to compensate. So your body's really compensating as long as possible until the end result is a systemic disease involving every single organ. This should be in your study notes, and you should look at this and memorize this. This is all the symptoms of end-stage renal disease or chronic kidney disease. So when you're reading and studying, really look at the staging. It's all dependent on the GFR. Know the staging, and when end-stage renal disease occurs, which is usually GFR less than 15 mils per minute. Clinical manifestations of the urinary system is usually polyuria early. Most people continue to have significant urine output. It's often difficult to tell patients, hey, you have kidney disease. This is actually occurring, because they are still fine and having totally fine urine output. Usually this occurs most often at night, and specific gravity fixated around 1.010. Usually oliguria occurs as CKD worsens. This usually requires fluid, or ends up that the patient has fluid retention and requires some kind of diuretic therapy. And then anuria is when the urine output is lower than 40 mils in a 24-hour period. This is usually when we're looking at dialysis or some kind of dialysis to pull off the things that need to be excreted. Metabolic disturbances, waste product accumulation is big. As GFR decreases, BUN and serum creatinine levels increase. BUN levels increase not only from kidney failure, but also from protein intake, fever, corticosteroids, or catabolism. Usually other symptoms you see: nausea, vomiting, lethargy, fatigue, impaired thought processes, and headaches. Electrolyte and acid-base imbalances. So a reminder, I've said it before and I will keep saying it, potassium is the most serious electrolyte disorder. It causes fatal cardiac dysrhythmias. Sometimes the potassium levels can even reach up to 7 to 8 in these patients. Hyperkalemia results from a decrease in excretion of potassium by the kidneys, breakdown of cellular protein, bleeding, and metabolic acidosis. Sodium. Maybe elevated, maybe normal, maybe low. It's one of those kind of catch-alls. It could be related to anything. Sodium retention can contribute to like edema, hypertension, or heart failure. And really we want to like decrease their sodium intake to really below 2 grams in one day. Sodium may also come from food, dietary supplements, drugs, IV infusions. So think of, your normal saline. So those are important things to watch for. You can also see hypocalcemia and hyperphosphatemia, and then sometimes hypermagnesemia. It is not usually a big problem. It's usually unless the patient is ingesting extra magnesium, such as magnesium in acids, those kind of things. Really, metabolic acidosis results from the inability of the kidney to excrete acid load and defective reabsorption and regeneration of bicarb. CKD, the overall goals. So a reminder that kidney disease can get worse. It can't usually get better, but it can get a lot worse. So we want early recognition, diagnosis, and treatment to deter the progression of kidney disease. The goal is to detect and treat potentially reversible causes of kidney failure, such as cardiac failure, dehydration, infection, nephrotoxins, urinary tract obstructions, glomerulonephritis, renal artery stenosis. There's so many. So we really want to find those and prevent those. We want to reduce the risk of CV disease, prevent complications, and provide for the patient's comfort, because this is a life-changing thing, especially if they progress to needing dialysis. Recommendations usually for hypertension therapy is a blood pressure less than 130 over 80 for patients. If they have significant proteinuria, really it should be less than 125 over 75. You really should do orthostatic blood pressures, which is when you measure supine, sitting, and then standing positions to effectively monitor effects of blood pressure drugs. This is when people pass out a lot of times because their blood pressure is great when they're laying down, but if they all of a sudden stand up, all of a sudden their blood pressure drops. Other treatments of hypertension include weight loss, therapeutic lifestyle changes such as exercise, smoking cessation, avoiding of alcohol. Diet recommendations, usually the DASH diet is something that they used to recommend. It's kind of adjusting now. It's not really called the DASH diet, but dietary changes to help really do help. And administration of antihypertensive drugs. Measuring of to decrease serum potassium, so potassium restriction, the IV glucose, insulin, IV calcium gluconate or K-exalate, or dialysis to really control that potassium. And then adjustments of drug dosing really depends on renal function. So digoxin can cause hyperkalemia in kidney patients just because of the degree of renal function. Nursing implementation, we're going to do daily weights. We're going to do daily blood pressures, identify signs and symptoms of fluid overload, and signs and symptoms of hyperkalemia, and strict dietary adherence. Just a reminder of the signs and symptoms of hyperkalemia: muscle twitching, cramps, those EKG changes that you can't see unless you actually usually look at the EKG, irritability, anxiety, abdominal cramping, and diarrhea. Dialysis is usually begun once the GFR is less than 15 mils per minute. This is usually when they have uremia. They can't filter out these nitrogenous waste compounds. Usually we try to do everything before we start doing dialysis because it is a life-changing thing. So just a reminder of dialysis, this is something you should really look into, is the methods of dialysis available and what it actually does. So here's a really pretty picture. It's also in your book. If you don't understand the process of dialysis, there's some YouTube videos, or really look at the pathophysiology of this because it can definitely help. Peritoneal dialysis usually is a membrane acts as, or the peritoneal membrane acts as a semi-permeable membrane, and with hemodialysis, it's an artificial membrane. So peritoneal dialysis is approximately 12% of patients receiving dialysis are on peritoneal dialysis, also can be called PD. Peritoneal access is obtained by inserting a catheter through the anterior abdominal wall. The techniques for catheter placement really varies, but it's usually done by surgery. And as you can see on the picture on the far right, that is the dialysis bag and where it kind of goes into the body and then excretes. And the picture on the left is an actual peritoneal dialysis site once it's healed. There's 3 phases of the PD cycle: inflow, dwell, and drain. Usually overall it's called an exchange. Output should be clear, same color as when it's put in. If it's not, this is something you should notify the healthcare provider of. We want to take a sample of that fluid and culture it, because if it looks different, it might be an infection. One normal finding, though, is the patient may look or appear bloated because you are putting extra fluid into their belly. There's really 2 different kinds. There's the automated peritoneal dialysis. This is probably the most popular because it allows the patient to do dialysis while they're asleep. The machine cycles 4 or more exchanges at night with 1 to 2 hours per exchange. It's difficult to achieve the required solute and fluid clearance solely with this nighttime. So it might be useful at the beginning, but it's not a really long-term solution. Usually 1 or 2 daytime manual changes may also be prescribed to ensure adequate dialysis. And then you have the continuous ambulatory peritoneal dialysis. This is usually carried out manually with 1.5 to 3 liters of peritoneal dialysate at least 4 times a day, with dwell times averaging 4 hours. So you can see it takes up a large part of the day. Complications of peritoneal dialysis: exit site infection, peritonitis. So if you think you have a direct line into the abdomen, what happens if we have some kind of infection go in through? That's why it's a very sterile technique to hook up this dialysis machine. It can cause peritonitis or the infection in the full bowel, which is life-threatening. Can also have hernias, lower back problems, bleeding, pulmonary complications, and protein loss. So the other option is hemodialysis. This is usually from a vascular access site. Obtaining the access site is one of the most difficult problems of this, especially since they can break or they can go away or have issues. So the arteriovenous fistula is probably the overall #1 that they use. It's called an AV fistula. It's the best overall patency and has the least number of complications. There are some situations where immediate vascular access is required. So sometimes they will go emergently into the IJ or internal jugular or the femoral vein and put immediate access in there. This is temporary, and they usually will try to get some other kind of access later. So here's this picture of an AV fistula. You can see they really sew this radial artery and the basilic vein together to cause this kind of shunting area. You can also have an AV graft, which is an artificial, and you can see that looped graft. That is an artificial, which means they usually have more likely to reject it, kind of more issues. So we prefer the AV fistula if possible. Here's a hero graft. You can see the cannulization. It really is going through the IJ area, and it's a huge cannulization. Overall, look at this graph to really look at the components of hemodialysis. Notice the heparin infusion. That's a big one. Blood removed via a needle is inserted into the fistula, or the via catheter lumen is propelled to the dialyzer by a blood pump. Heparin is infused either as a bolus before dialysis or through a heparin pump continuously to prevent clotting. The heparin pump usually is the better option. Dialysate is pumped in and flows in the opposite direction of blood. Dialysized blood is returned to the patient through a second needle or catheter lumen, and then the old dialysate and ultrafiltrate are drained and discarded. Here's another picture if you really want to look at the dialyzer. If this is kind of a more broad picture of this. So here is an AV site. We must protect these access sites. If they go away, you cannot use that arm anymore, and they have to go find other access sites. There should be no blood pressures done on that extremity to prevent access site from clotting off. You should also not do lab draws. You should not really do anything on that arm. There should be no IVs. None of that should be on that arm, but the big one is a blood pressure. Here's some more pictures of like the hemodialysis of like the right IJ catheter, the temporary hemodialysis catheter, and a long-term cuffed hemodialysis catheter. Before treatments, nurses really should look at fluid status, condition of access, temperature, and skin condition. You should also really check your dialysis site to make sure it is still good. And then during treatment, there should be an alert to any kind of changes in condition. We're really measuring vital signs every 30 to 60 minutes. Patients do sometimes get hypotensive during this process. So that hypertension that occurs during hemodialysis results primarily from rapid removal of vascular volume, decreased cardiac output, decreased systemic intravascular resistance. They can also have muscle cramps. Again, this is usually due to that hypotension, hypovolemia, and then the use of low sodium dialysis solution. And then loss of blood may result from incomplete rinsing of blood from the dialyzer, accidental separation of blood tubing, dialysis membrane rupture, or bleeding after the removal of the needle at the end of dialysis. The last piece of your module is the organ donation, which really is a gift. Kidneys are the most frequently transplanted organs. This can either occur from a cadaver or a live donor. If it is a cadaver, they want to make sure that they had no issues with their kidneys. So this usually involves a history and some different studies to make sure those kidneys are working. Or they can come from live donors. Kidney transplantation for treatment of chronic kidney disease offers the greatest chance of long-term survival and quality of life. The transplanted kidney is usually placed extrapyramidally of the right iliac fossa to facilitate anastomosis and minimize complications. So spend a little time reading about this. You don't have to go extremely in depth. There is a big empathy and emotional component when it comes to organ donation, especially if it comes from a cadaver, because that usually means somebody lost their life for somebody to gain this kidney. So lots of thoughts and emotions that go with that.